is May 21st. This is House Healthcare. And on our schedule, we do have Chair Owen Foster from the Green Mountain Care Board on 266. But Devin Green from Boz has asked to speak for a moment. So
thank you, and thanks for having me today. Devin Green from Vermont Association of Hospitals and Health Systems, and this is actually for H482. I was talking to Chair Foster on the way in, and I made a mistake in some of my testimony on H482, where I said that the UVM Health Network's independent monitor was up to $15 million. That included the consultant funding, and I should not have included that. The independent monitor for the Green Mountain Care Board is up to $1 million. And I will go back and correct my written testimony, but I just wanted to get that on. So thank you for the opportunity.
Real quick question about that. So the remaining $14 million, that's for the health network to hire their own consultants to help them with that's not for the Green Mountain Care Board to appoint consultants.
I believe so, but I will look to Chair Foster for the details on the agreement.
Yeah, Owen Foster from the board. So the liaison team is 3 people. They're being paid $250 per hour for their work. We have not set a hard cap, but we've been discussing that portion of the $15 million will be around $1 million, give or take. It's not anywhere near 13, 14, or $15 million. The other $13, $14 million is to retain teams of consultants to transform the UVM Health Network and its operations in the most efficient way possible. If we do not spend the 13 or 14, $15 million, it will be used for purposes consistent with the settlement agreement, such as improving primary care, Blue Cross, lowering rates, whatever it may be.
Thank you.
Thank you.
Morning. I just wanted to thank Boz for correcting that, as I think it's a big difference between 1 million and 15 million. The oversight is not that amount, and that's important to me. So I'm here on H266, and apologize. I didn't have a whole lot of time to prepare, but I think there's some really important points to discuss that have not yet been brought up. First, I do have to say that I do find it cruel to charge enormous markups on life-saving treatments to patients who are incredibly sick. Hospitals have argued that they use some of that excess margin from that patient care to make up for other services that lose money. I don't think that's much comfort to cancer patients who are fighting for their lives. I also think it's important that we understand the financial impact to the individual patient. Patients pay copays. They pay out-of-pocket costs. So if a drug is marked up 400, 500, 600%, that can increase the amount they have to pay while they're really ill. That's important. This is a made-up example. We can ask Blue Cross or the hospitals for a real example. But if there's a drug, say an oncology drug, that's $1,000 a month, or a Crohn's disease drug, or whatever it might be, and it has a 600% markup, which is around the average in Vermont, that drug costs the patient $72,000 a year. If they're lucky enough to have insurance and they have a copay, 20%, and a high deductible plan, they might be paying $14,000. If that drug is marked up 120%, they may only pay $1,000 or $2,000. So this has real impact on the patients who are suffering. It's very hard to deal that kind of math, bank account issues while you're ill. It was also suggested that the choice is binary. Do this, cut services. I do not agree. I flatly do not agree. Yes, our system needs to change and change dramatically yesterday. But A number of our hospitals have very, very significant reserves. We're at a moment where we can lean on those reserves to help patients, to buy ourselves time to solve this problem. I also think that there's opportunity to improve operations at a number of hospitals. We can cut waste. There's significant non-patient facing costs in our healthcare system. There are lobbying costs, there are marketing costs, there are branding costs. Why are we not cutting all patient facing costs first as opposed to patient care? Why aren't we leaning on our reserves first as opposed to cutting patient care? On top of that, the state and the hospitals have invested millions and millions of dollars on consultants and executive teams to work on this problem. We have $1 million, 2, 3, 4 that we spent on the Oliver Wyman report to give us a roadmap to deal with this. I believe the RHRC team that's retained by AHS is $2, $3, $4 million, somewhere in that range. Hospitals have hired their own consultants, many of them, millions of dollars. Why aren't we utilizing those resources to be able to handle this financial change? On top of it, we have immensely talented leaders at our hospitals and at VOS. We do. Let's challenge them. We're either going to make these patients pay that amount, we're going to risk Blue Cross's solvency, or we're going to challenge our leaders. I think we need to challenge our leaders, and I think they can do it. There's additional discussion of Medicare reimbursements being low, and therefore we need to charge these very sick patients exorbitant amounts. There are many reasons that Medicare reimbursements may be low, and I'm not sure that I necessarily agree with the premise. But have our hospitals maximize cost-based reimbursement for the critical access hospitals? Is Medicare just choosing to single us out and target us and pay us less? Or are there things that we can do at the leadership level to make sure we're maximizing that? For example, UVM obtained sole community hospital status in 2023. They did not have it before. My analysis is they could have $10 million a year. So that data that you saw, there's a question, which is why is it low? And can anything else be done about it? Shouldn't we maximize and push our leaders to maximize that before we go to cutting patient care or exploit ill patients? I also want to talk about the market dynamics that are very, very critical here. We are losing all of our small and independent practices. I apologize, that may be an overstatement. We're not losing all of them, but they are threatened, and the threat is real. So Champlain Valley Oncology and Hematology, where my wife got cancer treatment, they're reimbursed 110% for these drugs. That practice is closing. It is moving to UVM. Today, it's 110%. What is it tomorrow when the largest oncology practice in Vermont moves to UVM? What does that do to healthcare costs? Additionally, if hospitals have 1,600%, 6,000% markup on drugs, and a practice like Champlain Valley Oncology has 110, what does that do to our market? It consolidates it. It consolidates it in a more expensive place. We're losing the opportunities to have more affordable, also highly accessible and high quality care because of these crazy differentials. 110% for Neulasta at Dr. Unger's practice versus, I believe, 6,000% at UVM. It doesn't work. I talked about the patients and the cost to them when they're ill because of their copays being higher because of the drug costs. What about self-insured plans, right? So a lot of businesses in Vermont have what's called self-insured plans. You have Vermont Precision Tools in Swanton, King Arthur Flour in Norwich, VHI, which is your property taxes, Engelberg Construction in Colchester. They're self-insured. So let's say they have 100 employees and one of them gets cancer and they need these drugs. One super sick patient at any of these employers spikes
their costs for those self-insured plans enormously. Should that happen? What does that do to that business? If I'm King Arthur Flour, I look across the river. Can I go to New Hampshire? And if we're losing practices like Dr. Unger's, where do these people have to send their patients to a more affordable place? And I have to say that I find the cross-subsidy argument to be a loser. It's endless. Is it 300% we need to cross-subsidize? 6,000, 10,000, 100,000? What's the limit? And don't we cross-subsidize already with all these other services? Don't we do it with the highest outpatient prices, top decile outpatient prices at UVM already? We have numerous hospitals above 300% of Medicare, most of our PPS hospitals. Aren't we cross-subsidizing enough? When is enough? Give me the answer. I don't know it. And we say it's to cover costs. Well, let's ask why. Why are we losing money? Some hospitals make money on these services. Some don't, some do. There's independent primary care practices that struggle in Vermont, yes, but they can keep their doors open at far lower reimbursement rates. It's apples to oranges or different practices. I understand that. But we have a system that's been designed around providing all the care in places that cannot afford to provide it effectively. It's not going to work. Now, are we losing money on services for other reasons? I'm making up examples. This is not any data-driven answer here. But is it because we have too expensive an administrative apparatus? Is it because we spend too much on marketing or legal or something else? Is it because we have long wait times and we're inefficient, so we don't have enough volumes? Is it because we have too many hospitals doing too many things and there's not enough census to sustain that practice? Is it because we don't have enough staff? Is it because we are supporting the medical school? Is it because we're spending $100 million in New York? What is it? It's more than just the service line. Those costs include a whole bunch of other things. It's not just the service line. I do want to say that I've been working with VASA and a number of hospitals very closely on this problem. I believe Mike Fisher referenced the May Day meeting. And I did ask with other leaders in the state for the system to provide effective provider-led reform that ensures we do not have commercial rate increases above 5%. I don't think our market can handle it. I don't think our people can handle it. I hear a different tone from the hospitals. I know they're working really, really hard at this. I know they are. But we have to show receipts for the people. I have a rate request for 23% in front of me. The talk of reference-based pricing 3 years down the road or working together, that's good, but it's not now. We need something that is now. I think that there could be an opportunity if people want to put their money where their mouth is, submit a letter to the board with Blue Cross, and hospitals, and MVP, and say, we don't want this price cap, but we are committing that we will ensure there is no more than a 5% rate increase. That's a good step. But it can't be an ambiguous, we're going to get there. It has to be real. I have to vote on these rates. And even if there were that, it's still unfair to the cancer patients or the Crohn's patients. It's unfair to the dairy farmers. It's unfair to everyone. So I think this is a serious measure. I think it's fair. I think it's hard. There's no question. But what are we going to say we did now for this problem? Ultimately, I think if you vote for this bill, you're voting to help those patients and to help the immediate crisis of our healthcare affordability problem. I did put together a couple slides. I'll go through them real quick. It is true, Vermont is the highest, most expensive state in the United States of America for hospital-administered drugs, and it's not by a small margin. Rhode Island, Massachusetts. You see where they are? You see where we are? It's not acceptable. It's not okay to say that to your constituents. It's not. After, hey, here they are. They're as old or older, and they're right next door. They're a fraction. Next slide. I talked about, is it as binary as was presented? Do this, we cut services. That argument is inappropriate to make it. People who tell you what they can do, and there's people who tell you they can't. We need people who say they can right now. And we need people who find a way. One way is to look at the reserves. And if we have to lean on the reserves at this time of crisis, then let's do it. So this is the UVM Medical Center. I'm just going to go to this number. This is the total obligated group, all of the network, okay? $361 million in cash in the bank as of the end of fiscal year 24. $248 million in short-term investments. $705 million in board designated assets. This is what we call unrestricted cash. That's about $1.3 billion. The medical center alone, 234, 110, 467 million. Those are the reserves we have at the medical center. Health network, that entity itself, that entity has 68 million, 107 million, and 115 million. If you can go forward 2 slides.
Can I ask a question about it?
Yeah.
Yeah, please. Is the UVM,
I need to look at it. Okay, so you said UVM Medical Center total assets was about 2 billion, and then the UVM network is 1.2 billion. Do they overlap or are they separate?
Sorry, go back 2 maybe. Yeah, so this is the medical center, the hospital, and these are its assets. Okay, so 234 million of cash.
Yeah,
Then you have the health network, the parent entity, that is 68 million cash, 107 million short term, and 115
so those are separate accounts.
separate accounts. And then the total for all these hospitals and the health network is here.
So $3 billion.
I think it's about $1.3 billion.
I'm just looking at the lower right, just,
Yeah. So with some of these others, those are not unrestricted cash. So it's
Okay.
like property and other things. I wouldn't count those as liquid or immediately available.
okay. Thank you.
And they also may have liabilities that go against them. So I'm just focusing on the unrestricted cash.
Thank you.
I think I just want to highlight that when you look at the network, that's the network. They're not a hospital. They don't provide direct patient care. That's it.
That's correct.
That's the network.
Correct.
And that's 1.2 billion.
No, 1.3-ish for the network and each of its 6 hospitals. The network itself, that operating entity is here, 68, 107, 115.
Yeah.
I will say, I actually don't find that to be as much money as it appears because of the size of their daily expenses. So I think it was about 145, 147 days cash on hand, which is not, in my view, excessive. But we're in a moment where we need to find the money. And you're either going to find it in your constituents' pockets, in your businesses, to pay these high drug prices, or we're going to find it in the insurer, except they're nearly broke. I don't have many options.
Sorry, I know this isn't what you're, but look at, what are restricted assets?
Yeah, they might be things like if a wealthy family were to donate money and say you can only use it for this purpose or for that purpose.
Okay,
thank
So,
you.
yeah, you also have a large amount of restricted assets. So the network has 822 million of restricted.
Sorry, I'm delving into all the numbers here. Leslie,
I understand, yeah. So when you talk about used reserves, what are you pointing to on this?
Well, I think if I remember the testimony, the medical center would lose, is it $60 million-ish if this bill were to pass?
Mhm.
What I'm suggesting is perhaps they can handle it for a year.
And where would that be on here?
Here,
Okay, so you add those up and that's
1.3,
1.3 billion.
give or take.
Thank you.
What I'm saying is, I don't think it's as binary as if you do this, we cut a service tomorrow. I'm saying you can lean on the reserves to not cut services to get you through the rainy day, to buy time for the Mike Smith team and the Rural Health Redesign Center at AHS to work on this, and for the executives to do their job, to get us through this. You're making a choice. Are you taking the money from the patients and the businesses? Or are you using some of this money to get you through? I don't know how you tell a cancer patient, I'm sorry you're sick, but you're the solution to our financial problems. I don't know how you do that. I don't. 2 slides forward, maybe. The bill had an important amendment, which I support, which was to exempt the critical access hospitals that are independent. So Newport, St. Johnsbury, Copley, Mount Scottney. Oh no, Mount Scottney is part of the network. Springfield, they would not be involved with this bill as you currently have it. So again, is it a binary choice? If you do this, we'll cut services. And I just want to point out some of the days cash on hand at some of the hospitals that would be potentially involved. Rutland has 243 days cash on hand. That's a huge amount of cash on hand. UVM's is a little, I think there's also the network assets. So there might be some adjustments that need to be made or considered when you look at UVMs because of the network operations. Same with SVMC. They're not really at 52 because they have a parent entity as well. I think they're more like 180, 170, 190. So that's quite healthy. If you look at the S&P definitions, I believe it's 110 days and below is a vulnerable or highly vulnerable hospital below 110. The ones we're really talking about, UVM, Rutland, Northwestern, 256, they're well above that vulnerable range. Brattleboro is low and declining pretty quickly. Eastern wouldn't be involved. SVMC, like I said, is more like 170, 190 realistically, and they're part of Dartmouth. Next slide. There's the next slide, I forget.
That's it.
Okay. So
Well, she wrote.
yeah, I mean, there's no question I have that this system's going to change and change real fast, and it has to. And sometimes when you put this kind of pressure on, you get good results actually. Because if you don't put the pressure on, you're basically saying we're okay with this. I'm not okay with it. When the board has reduced some rates, we've actually seen some positive changes. We've seen some additional effort to increase access, which has been beneficial. We've seen a reduction in administrative costs at UVM, which is positive. And before that, when we didn't give reduced rates or more price pressure, we didn't see that. I think that the hospitals with their leadership and their expertise can handle this. It will be tough, but it's going to be tough on your constituents otherwise.
Lori.
So I just have a couple notes I've jotted, and I'm not sure this is going to come out coherently, so I apologize. I feel like this committee in particular has stepped up this year to really try and move various pieces in an effort to shore up our healthcare system, obviously with the help of everyone in this room. Some like it, some don't. At the end of the day, where I still have questions are, we haven't done anything to dive into the insurance situation other than to say we need to save it, right? So we did put in 126, I think a report back from DFR. like, that's a concern for me. And I'm not asking you to answer this, but that is a concern for me. The other thing is, how do we connect everything we're trying to do to decrease premiums and costs to Vermonters?
Mhm.
So the hope is that when this is passed and the hospitals I agree, very smart people leading these hospitals, and with Voz, they're trying to do the right thing, and they do the right thing, and yet there's still some services that they cut, right? So then there's going to be a backlash of, well, we need lower costs, but we didn't want to cut anything. How do we explain the connection to Vermonters that this is really going to lower costs for them? And then what do we do? What do we do in the meantime? Like, how are we really, do you really think what we're putting on the table and what everyone is doing is driving towards systematic change in the next year?
Yeah. I can take each of those. So Blue Cross, the insurer side, I agree with you. I think there's more understanding to have there. But really looking at some of their data that we see, it is predominantly claims costs. So to the extent they're performing inadequately, they're paying too many claims, or they're not having strong enough contracts. I don't know, like if 96% or 95% of their spend is on claims, then your problem is with the claims.
Right. And so I apologize for interrupting, but, and you don't have to answer this, but like just in general, I'm thinking, okay, to that then, are we looking at those claims and where they are? And can we move some of that into lower cost care? And who is looking at that? Again, nothing for you to answer, just more like to put out there. Because if that's the case, claims are just going to keep going up as we get older.
Yeah, agreed. And that was part of what we discussed in the May 1st meeting was, are there opportunities to use some of the Blue Cross data to move some of these expensive claims elsewhere, or have risk sharing contracts where a hospital bears some of the risk on these high cost patients? Those are some of the discussions. DFR has, forget the right language, but they are looking more closely at the operational side of Blue Cross giving reserves. So I don't think that's not warranted given where things are. You just have to check under every rock at this point. The next question you asked was about the connection. You're right. A number of steps you may take. If you close the service line here, do the patients go there? Does it cost more when it goes there? You might not end up saving money. You could actually end up costing more. Who knows? Those are very hard analyses. So for example, if you also have an understaffed hospital, do those nurses go to the other place who now has a service line? Do those physicians, and now you don't have the traveler costs at two places? That's a whole nother analysis that is more indirect and more nuanced and difficult. This is actually straight dollars. This one's actually directly connected. It is literally directly connected to the copays. When a patient goes to Champlain Valley Hematology, it is a fraction of the cost because the claims cost less. So one, directly to the patient's pocket. Two, the insurer. The insurer is paying 110%, not 6,000. That's an extreme example. There's others that are more close, but you can just see where Vermont is. We're just way out of whack.
And sorry to interrupt. Will you be able to show that during any of the rate filings or in any of the analysis that you all do going forward?
So the rate filings are a contested case and the record is pretty limited. We can ask that, but all of these things that are happening, like the May meeting and like the Voz work and the RHRC work, those aren't solid enough for Blue Cross to say, hey, we heard testimony of the hospitals, they're really working hard, we're going to reduce our rate by 7%. That's not there. So what we need is something that's tangible, committed, and that has receipts, so to speak. This will directly reduce Blue Cross's rate by 4%. Direct. So yes, this one is direct. It is not without difficulty as you reduce expenses at hospitals or revenue. You're either going to take it from here, or you're going to take it from there. That's the hard decision you got to make. I'm sorry, and the last question I think is really critical. The system. We have kicked the can down the road, in my view, on fixing the system for a very long time. And that problem is coming home to roost. These problems are not just Vermont. Rural hospitals across the country cannot make it. It is a business model that will not succeed. We have kept this business model alive with these insane prices. And you're either going to tell you Vermonters, we're okay with this, and we think this is the right thing in our judgment. We're going to keep going up 20%. And here's why. Or we're going to change the system. There's a lot of this is coming faster than I think we had predicted. When we did the Oliver Weimer report, we're in all your communities last summer. I thought we had more time, not a lot more time, but it's coming really fast. So what we are getting and experiencing is what the rest of the country has gone through over a period of 10 years, and we're getting it all at once. And that's very hard. So that kind of analysis of like the connection of cutting a service here and there, I don't know that we have the luxury of time to do that. And that's why I'm suggesting maybe we need to do something to buy ourselves time. And I do believe the hospitals are committed to this. If there's another suggestion with a dollar value on how we can do this, I am all ears. I am not open to accepting that Vermonters are going to pay 23%. I'm not open to that. And I'm not open to cancer patients paying these kinds of prices. I'm not.
What do you?
What happens for a cancer patient that receives their treatment in Dartmouth that has Blue Cross Blue Shield? What can you, I don't know what Dartmouth charges, whether it's exorbitant or what, but do you have any insights into that?
Really good question. I've not done a cost comparison across neighboring hospitals in other states. There will be crazy ups and crazy downs kind of across.
It doesn't have to be Dartmouth. It could be a hospital in Boston.
Yeah. Generally, I mean, looking at the national data, Vermont is the highest in the country. So I would presume if it's consistent with the national data, it will be a fraction of the cost. So if Boston Massachusetts hospitals were what, 48th in the nation, around what, 200-ish% on outpatient drugs, something like that. I don't remember the number. No,
200.
yeah, all right. Well, that's less than 600. So they might save a lot of money. But again, maybe on one particular drug or that particular drug, that hospital is higher than that. I don't know how they are.
Any other questions? I think just really quite simply, in thinking about what you've said, well, why do hospitals even keep reserves? What is the point of keeping a reserve? Why do you need to keep days cash on hand? It's for when something bad happens. You know, if your claims stop, if you have a cyber attack, isn't that why we keep reserves?
In my view, those are very valid reasons to have reserves.
And if we're in a crisis and we're in an emergency, maybe it's time we started using the reserves, because
It's not a perfect or a long-term solution at all, because they only last so long. And it can impact their financials, and it can impact their financials with their lenders, potentially. But that's why I'm open to other solutions if there's one that can actually drive these rates to something reasonable. I haven't heard anything hard and fast that gets us there yet. But yeah, I think the reserves are for that. But keep in mind, like it is like with 482, if you lower these reserves, maybe they go from AA to A+ or something. But Blue Crosses are what, a C+? And what about the family who's paying $3,000 now in copay rather than one? What about their reserves? What about their credit rating? You can't look at this stuff with one eye on one person and one constituent. What about an independent practice? What are their reserves? I can tell you that Howard Center is like 5 or 6 days. And they're self-insured. And their healthcare costs have, I think it's doubled in 5 years. They get another cancer patient that goes to UVM. What about their reserves? It's just a very complex problem. We need more time to solve it. I hate to say we need more time because I don't think it's acceptable, but I don't have much better for you.
Sure.
And since you brought up the patient, how about the patient that goes home and instead of trying to relax and get well and beat the disease, they're worried as hell about how they're going to pay it. And they're not going to get better, maybe. Or it's going to take longer. And they're still going to have that problem at the end of how am I going to pay for either the premium or the amount of copay that I have to pay at this point.
Yeah, I agree. I think that when people are this sick, it's really cruel to put this on them. It can't be how we finance our healthcare system. It can't be. It can't be. And part of the amendment that I think you had in your bill was that if this was a serious, or I don't know what the language, but an impact on access and quality and sustainability, a hospital could ask for additional money somewhere else, which I'm open to. I think I made that suggestion. We don't put our money where our mouth is. So we talk about preventative care, primary care. Well, they lose money at hospitals or many hospitals, but then the cancer patient pays 6,000%. That's not putting our money where our mouth is. So that addition to your bill allows a hospital to say, hey, we're losing money at mental health. We have a crisis in mental health. Can we charge a little more there to offset some of this big loss here? I think that's a reasonable discussion to have.
That reminds me, do you think that that language is too constrictive? Should it be a bit wider? I mean, the way I'm reading it right now is that those are the only places where you could say you could increase revenue by. Should the board have more discretion? I guess is what I'm asking.
So I would say it's not too restrictive. And the reason why is because they can submit any budget they want, really. So, I mean, they can come in and ask for 10%, even though our guidance is 3%. And so even if they're not making up for it here, they can just say, we want to raise our price. So there's a lot of flexibility there. But I mean, if our healthcare system requires this to sustain it, I mean, our healthcare system's doomed. If this is what we're doing to sustain it,
Sorry.
To your question, in that language, it says may propose to increase commercial reimbursement rate for preventive care or essential community services. What exactly are essential community services?
people can define that differently. There is a definition, I think it's from the American Hospital Association or American Academy of Physicians, I forget which, but there are ways it's defined. And it can be different for different communities if you have different needs. But generally speaking, I would consider it primary care, preventive healthcare services, emergency care, things of that nature.
I have a sort of an unrelated question because I keep forgetting, we're getting caught up in the ASP aspect of this amendment and forgetting the underlying bill. The underlying bill that we did months and months ago was around 340B. And we put provisions in there because of some unfair practices that the manufacturers with contracting pharmacies. And a lot of that was because of lost revenue from hospitals. And we fixed that. And I was looking back at the testimony, and Va's testimony said that the actions of manufacturers have directly impacted hospitals and have included hospitals having to ask for additional commercial rate increases in 2024 because of the loss of 340B. And I'm wondering if you have any recollection of any hospitals requesting increased rates because of what we've fixed, that they asked us to fix in this bill.
I can't off the top of my head. I mean, there's a lot of budgets and a lot of line items, but generally that is how they approach budgeting, which is if there's a shortfall from Medicare or 340B or anything else, it gets put on our commercial market. That is part of our problem here, is that this is an unsustainable model, and any shortfall goes to excessively high commercial prices, whether they're here or MRIs or CTs or anything else. And that's just not acceptable to our business community. It's just not. I mean, so the Supreme Court yesterday, we were being appealed, and we were being appealed this morning at the Supreme Court. And I was at a court virtually a week ago on this. And part of the argument was that the board needs to do the math to come to a precise number. So if you're going to give 5% instead of 6%, you got to show the math and do the math. Many of the factors we look at are not numeric. There's not like a formula that you do. And I was thinking, well, if I were to do a formula, what would I do? I would say, okay, well, much does it cost to take care of this commercial patient? That's how much money you can have from that commercial patient. Well, like, it's very unfair to put all this on such a small, crushed commercial market.
Okay. Thank you.
Thank you.
Thanks for coming in.
Good day.
I think we're gonna take a short break, maybe 15 minutes. And then